Yes, so we are live on YouTube. So we've had a break over the last month and we are resuming again this month. And this is going to be an exciting session. So I hand over to Hamshi to start the meeting.
Thank you, ma'am. Welcome, everyone. Thank you for joining us for today's talk. I am Hamshi. I am the speech therapist at Aster Whitefield Hospital, Bangalore. I'm going to be your moderator for today's talk. We already know autism is a neurotype in which the individual's brains are wired differently, which means they view the world or the way they experience the world is different. We are also familiar with the interventions, the behavioral interventions or psychological interventions or educational interventions for children with ASD. Something that we are going to discuss today is the medical or the pharmacological interventions in children with ASD. And the speaker for today is Dr. Soumya Shri. We welcome you, ma'am. Dr. Soumya Shri has completed her MBBS. Dr. Soumya Shri has completed her MBBS in KIMS Bangalore and then pursued her MD and PhD program in clinical neurosciences from the Department of Child and Adolescent Psychiatry at NIMHANS, Bangalore. She has immense experience working with children and adolescents who have developmental problems, including autism and ADHD, learning and behavioral problems, family and school-related problems, and childhood psychiatric illness. She has conducted over 500 workshops for children and parents across the country. She is on the editorial board of International Journal of Child and Adolescent Mental Health and is a board member representing Asia Pacific region for the International Society of Autism Research. She worked as a consultant at Rainbow Children Hospital and Aster CMI Hospital from 2016 to 2019. She is currently working at St. John's Medical College and Hospital and has her child psychiatry clinic. Apart from her profession, she also has many passions. She is a certified artist of Doordarshan and a Vidushi in Bharatanatyam. She has trained in Carnatic classical music, Western guitar, and has acted in many theatre plays. She continues to give performances and concerts in parallel. She runs a children's club called Tite Sante with a goal to enhance moral values in children and make them better citizens of this world. She has her YouTube channel and designs and publishes her own line of children's products. We are really looking forward for today's talk, ma'am, and we really welcome you for the talk. And over to you, ma'am.
Thank you very much for the kind introduction, Hamshi, and Dr. Gauri. Thank you so much for having me here to discuss this very relevant topic on medication for autism. I'll just share my screen. Just let me know if it's visible. Hamshi, can you see the screen?
Yes, ma'am, it's visible. We can see
Okay.
it.
Okay, all right. So welcome everyone. As you have heard in the introduction, just to give a background of the work I do and the place I come from. I have been seeing children with autism for more than a decade now. And I also do autism research, which means that there are a lot of things about what is known in the current literature, what the West is doing, and the status of all of these things in India that probably I can give you a little bit of background about or talk about. My talk is probably going to be for about 40 to 45 minutes. Most of it is going to be more interactive so that we can have more discussions on really things that are relevant to all of the participants here. I know that this is a mixed group of both parents and therapists, people who are probably some of you are also self advocates who are running organizations related to autism or have your own centers where you're catering to children with autism and developmental disorders. So I've tried to keep this talk a little bit broad so that we can discuss the role of medication specifically, but also look at all the scenarios that generally parents approach with or therapists probably should have an idea about before referring to a doctor. So when I say medication for autism, very typically, before even families come to me, they would have met a developmental pediatrician, they would have met a general pediatrician, they would have checked with their family physician, or they would have checked with their pediatric neurologist, or sometimes even doctors like pulmonologists, ENT specialists, ophthalmologists, because some of these things initially when symptoms are noted, it's not necessary that you parents are approaching, families are approaching a really specialized person. It's somebody whom they see on a day-to-day basis or a monthly basis for their child's regular health is who probably pick up some of these symptoms in the beginning. So just to start off with, let me give you a case scenario, right? So all of you in some way or the other who are participating here knows a child probably with autism, right? So let's assume that there's a 3-year-old girl who has mild developmental delay in all the areas. So the child has developmental delay in speech and communication skills and some bit of motor delay, cognitive delay, and all of these aspects. She is verbal. She's able to express her needs and ask for things, though she's not completely able to communicate because of the developmental delay. She is verbal, but she has behavioral issues like severe irritability, head banging, biting, kicking family members, hyperactivity, and so on. And then she goes to daycare. So because of she's in pre-nursery, the rest of the day she spends in daycare. And in the daycare, has started biting caregivers in the daycare center. However, she has never shown any aggression towards peers. So she's only doing it when there are adults around her. When she has her own age group of people around her in her daycare center or in the school, she isn't really showing any of these behavioral symptoms. She is not being able to manage in therapy sessions or in the early intervention center that she goes to. So therapists who are attending this meeting, what else will you ask if there is a child like this? What else? You can put it in the chat box because there are a lot of people participating in the meeting. So quickly, can you tell me what else can you ask if there is a child like this who comes to you? Apart from all of these things, what else do you want to ask? What do you want to know more about? I'll give you a minute or so. You can type in the chat box. Everybody participating can type in the chat box. Anybody, any thoughts? No? Do you think this much of, yeah, go ahead. Somebody, I think just unmute.
Wanted to add sensory issues.
Sensory issues. All right, good. Then somebody has written in the chat box, what are the triggers? What triggers all of these behavioral issues? Yes, that's right. Anything else? Sorry, what is DET? Okay, diet. Okay. Supriya says diet. Sri Leela also says diet. Very good. What else? Okay, good. Yes, Anjana says she'll collect ABC data. So for those who don't know what is ABC, antecedent, behavior, and consequence. So why did this start? So it's again related to the trigger. What started this behavioral issue? And during, if there is a trigger, what was the behavior? What kind of behavior? And what is the consequence? What happens after the behavior is over? Okay, good. So you have some ideas of what else to ask. So then let's say we did an evaluation with MChat, and yes, sudden and repeated regression. Absolutely, I agree with that. There could be regression, which is sudden, and these things could have started because of that. And you do an MChat, the child fails on critical items, you do INCLIN, and she gets a diagnosis of autism. Now keep this history in mind, and I'll take you through my presentation, and we'll discuss this again sometime in the presentation. So you have signs and symptoms of autism, and now we all know the new diagnostic criteria of DSM-5, where it's more broader. A broader perspective is given for diagnosis. So we have a lot of mild cases and high functioning autism, all of it coming under the same umbrella of autism spectrum disorder. So I'm not going to go into details of what is the current diagnostic criteria that is listed, because this is available on the internet. But apart from these core symptoms of autism, the repetitive behavior, stereotypes component, and the speech, social communication delay component, um, it is also extremely important for us to see if there is an association of the diagnosis with any other medical condition or a genetic condition or an environmental factor, or even for that matter, another neurodevelopmental condition, a mental health condition, or a behavioral disorder. A lot of times, if you recall from your own cases that you have seen, or the children you're dealing with, or parents for that matter, it's never that you see somebody with just the core symptoms of autism, right? It's never just, yes, this child fits perfectly into only the DSM-5 criteria of autism. It is not possible to be like that, because it's a neurodevelopmental condition. And because it's causing issues with the neurodevelopmental trajectory of the brain, it is causing deviations from the normal circuits that the brain should have developed for that particular age. A lot of times, I should say 90 to 95% of the times, there is always some other medical, genetic, environmental, neurodevelopmental, mental health, or a behavioral problem that comes associated with autism. So most of the time, when we are diagnosing, always it's important to look for what else is there that we are missing. Somebody said sensory processing issue, regression, dietary issues. So all of these things truly are not under the core DSM-5 criteria. But like you all have already said, they kind of contribute to the whole symptom profile that we see when we see a child or an adolescent with autism, right? So what is really important is how we diagnose. So necessarily diagnosis should not just happen by some tools or some forms that parents fill or something that we do, but it should be a combination of a clinician's observation, the caregiver's history, like what parents have noticed, what father has noticed, mother has noticed, sometimes what grandparents have noticed, or sometimes what the nanny has said, and also very importantly the school teachers, or maybe if the child is not in school, what is the observation from daycare, what is the observation in the from the neighbors, probably what is the child like when the child is in the park, or in the play area, or when they go to a family function or is in a party. So what are the kinds of things that people generally say or give input about this child, and putting all these things together to form the diagnosis is extremely important. Now, why is this important? What else should we really look at in a more important with more emphasis, right? One is you're looking at impairment in communication. So yes, there is communication delay. There is problems with social interaction, social and emotional reciprocity. But what is that impairment? How much is the impairment? Is it mild? It is moderate? Is it severe? Are there non-verbal communicative behaviors? A lot of times speech has not developed, but the child is able to indicate a lot of things just with actions, or pointing or holding the mother's hand and showing what exactly the child needs, or even maybe just pulling down the pant indicating that I have to go to susu, or holding up a cup or a spoon to show that I am hungry. So are there some of these non-verbal communicative behaviors? Is the child able to develop and maintain and understand relationships, for example, with their siblings, with their grandparents or uncles or aunts or something like that? Is the child really having a lot of fixated interests? And these fixated interests are why? Is it just because it's a stereotypic behavior under the autism spectrum? Or are there other sensory issues contributing to a diagnosis of a sensory processing disorder? Or is there something else that we have to really go in depth and look at? Now, if I have to go back to DSM-5, what DSM-5 also is telling us is to look at what is the severity of the level of autism. So it's not just about identifying, yes, this child falls under the criteria, but if this child is falling under the criteria, whether this child has the requirement of a very substantial support where verbal and non-verbal communication skills are severely impaired, not able to express even for toileting, not able to eat by self, not able to understand danger, constantly needs somebody to directly be taking care of the child, or always is in great distress, or is requiring some bit of support, substantial support, but in some way can speak simple sentences, maybe can cry and express that when they are in distress, probably able to communicate with their own parents and things like that. And some children who just require support. So they don't need everything to be done hands-on, but they're able to communicate, they're able to function in a let's say in a daycare center, or even the caregivers in the school are able to understand what they need. They're able to just adequately fit in some form of schooling setup and not having a lot of behavioral issues. Now, before going to why medication is needed, one of the things that we have to understand about developmental disorders always is most of the time, unless there is a medical issue, the onset of a developmental problem usually is invariably during infancy and childhood. So a lot of times parents will ask if, did my child was okay and suddenly at 7 years of age something happened. Would you call that a developmental disorder? Not really. It has to invariably start during infancy and childhood. Again, this is related to the functions that are related to biological maturation of our nervous system. So what do I mean by that? By that, I mean that there is delay in developmental milestones, and that happens because of the delay in the maturity of our nervous system. So when the child is growing, the brain is not maturing according to age, and because of that, there is a delay in development. It usually is in a continuum. So it's never like everybody, like you all have heard of the term, right? If you're seeing one child with autism, then it means that you only have seen one child with autism, because we know it's a continuum. It can go from mild, moderate to severe. It improves with lifespan. So irrespective of whether somebody is doing training, not training, just doing something at home, there will be some improvement that you will see in over the lifespan. But why intervention is necessary? Because it can greatly improve the outcome for the family, greatly improve the outcome for the child. And because it's a developmental problem, it's not just going to affect one domain of life. It will affect multiple domains of life, including schooling, friendships, relationships, education, marriage, social life, and so on, employment, and all aspects, because it's a developmental problem. Again, if the brain is having abnormality in the way it's connected, let's say there is a deviation in development, it for sure increases the risk for a psychiatric disorder, a comorbidity. So children with developmental disorders inherently, genetically by birth, are vulnerable to have an other psychiatric or a medical disorder as a comorbidity. So the percentages of a lot of things like schizophrenia, depression, anxiety, suicidality, ADHD, seizures, and all of these things are significantly higher than what it is for the general population in individuals who have autism spectrum disorder or intellectual delay or any other form of developmental disorder. And always, like I already said, developmental disorders tend to overlap. And again, for a lot of parents who ask the therapists or doctors, what is the cause? Why didn't my child get this issue? get this disorder. Like I had a normal delivery, the child was born okay, cried okay, but still, why did the child develop autism? And all research shows that autism is likely to have multiple causes, so it's never one particular cause. And it tends to run in families. What is known is genetically, if there is somebody with a developmental disorder, with a psychiatric disorder, the risk of a child getting another developmental disorder is higher. And of course, all physicians are not usually trained in early diagnosis and intervention, and that is why even to this day, in our communities and in our cohorts of patients, we continue to see a lot of doctors who probably would say, "Okay, your child is 2 years old, 3 years old. Speech may come a little late. Let's wait till 4 years. Let's wait till 5 years." And that definitely the scenario is changing, but not adequate enough. So why do we need early diagnosis and intervention? So when I say intervention, it's both psychosocial, behavioral, early intervention, and also medical and pharmacological intervention. So I'll come to that. So why do we need, what is the rationale for intervention? One is to try to see if, because this child has deviation in brain development, can we, by doing good intervention, foster optimum development? Whatever this child's brain has the capacity for, can we give a push and try to see if the child can attain the best possible scenario of his brain development? So that is one of the reasons, what is the rationale for early diagnosis and treatment. Second, there is something called neuroplasticity. I will talk about this in the next slide. I'll come to that. Third thing is the effect of stimulation. So the more we stimulate, the more the brain will develop circuits. The more the brain develops circuits, the better the brain will learn. The more the brain learns, the lesser the symptoms, the lesser the behavioral issues, lesser the chance of developing comorbidities, because we are trying to rewire the brain at an early age, in which way we are also trying to, in the long term, prevent some form of vulnerability, reduce the vulnerability to develop a medical or a psychiatric disorder. It definitely will prevent secondary handicaps, like some child who absolutely never had an intervention probably has lesser chance of being able to be employed somewhere versus somebody who has been in an early intervention setup, then gone to a special school, then gone to vocational rehab, has learned some hand skills and is able to function independently, probably has a far better chance of getting an employment opportunity or living an independent life with less comorbidities and fewer behavioral problems, right? So if I have to talk about the role of neuroplasticity, so let's say, you all might have heard this term of neuroplasticity. It's basically an ability of our brain to keep rewiring itself, to keep adapting to all of the environmental challenges that we face, right? So let's say, it's really very hot. What do? We think about turning on the fan. If the fan does not work, we try to get a cooler. If the cooler doesn't work, we try to get an AC. We try to shut off the windows. So it's basically our brain is trying to adapt to these environmental changes. At the same time, if we give the brain new experiences, like a 70-year-old wants to learn a new language, is it possible? Of course it's possible, because the brain can reorganize the pathways, the circuits for new experiences and newer learning. And this is something that our brain can do throughout our lives. Yes, early intervention is very essential because initial 2 years of age, brain growth is happening really rapidly. Until 6 years of age, brain growth is happening and we almost achieve the adult size of brain development. But our brain has the potential for learning through new experiences throughout the life. So yes, it is very vital to do a lot of things before 6 years of age. But even after that, children can learn a lot of things, a lot of newer experiences when offered. A lot of these behavioral issues and other things can actually go down. Now, one of the things that I really want to highlight, especially when I'm saying that we have to, especially if I'm going to talk about pharmacotherapy, is there are other issues that a lot of times parents and therapists and doctors don't really talk about. Like, if there is a child with autism, how many of us actually look at motor development? Is there a delay in motor development? Do we do anything about it? Yes. Sometimes in occupational therapy, we do deal with motor developmental issues as well. But a lot of times it's something that is easily missed. Sometimes presence of savant skills are really not talked about. Self-help skills, no. If the child is just doing speech therapy and occupational therapy, lot of people just don't talk about self-help skills. What about independent eating? What about independent toileting? What about wearing clothes? What about brushing teeth? So some of these things really are very, very important, but are not adequately addressed. It's also very well known that children with autism have better visual learning than auditory learning. So are we using enough number of visual cues in the environment to stimulate the child? One of the things that I do when I see children in the clinic is also to ask about what are the child's strengths. So irrespective of however severe the autism problem is and the developmental delay is, if you ask a parent, what is your child's strength? 100% they'll tell you something. This is what my child can do very well. Probably he will remember to lock all the doors before sleeping, or she will remember to, make sure that her clothes are kept in the cupboard. Some small skill. So you start from the strengths because we are really wanting the child to move towards a lot of positive behaviors and gaining a lot of positive symptoms. Now, why are we talking about medication? Because when I said that it's a spectrum, it can go from mild, moderate to severe. And like I said, it usually does not just occur alone as autism spectrum disorder. What I mean by that is there could be multiple other comorbidities. There could be seizure, there could be inborn errors of metabolism, there could be intellectual delay, ADHD, OCD, anxiety, behavioral disorders, self-injurious behaviors, very common, head banging, self biting, a lot of stimming that can cause physical harm and behavioral issues, emotional regulation issues where the child is throwing stuff or hurting himself or hurting somebody else in the family or in the school. So, all of these comorbidities can occur. Of all of these things, one of the most important things that should not be missed is seizures. So what literature says is, though here it says 25%, I think the latest literature says it can be anywhere between 30 to 80% that children with autism at some point in their lifetime can have a comorbid episode of seizure. And because of this, what we also see is seizures are at their peak at two time points. One is before 5 years or 6 years of age, and the other time point is during adolescence. So these are the two periods when we see a peak of seizures in children with autism. Again, there is not enough work in this area to prove that seizures, what kind of seizures happen in children with autism, how do we predict who will develop. So many times parents ask me, how do we know if our child is going to have a seizure? There is no way we can predict that somebody will get a seizure, but probably if there is already a seizure, continued medication will definitely be helpful to also impact the developmental trajectory. So if we treat the first attack itself, first episode of seizure, then the improvement in the developmental domains, in the behavioral domains also are definitely very significant. So what is really important for me whenever starting medication or an intervention program is probably to get children and families together. So it's not just something that we want to do with the child, but something to do with the family as a whole unit, and getting started in an intervention program, which means we also have the therapists on board. But what is really important is to understand what are these goals and what are the methods that we are using for diagnosis and assessment. So it's very important to have everybody on board before doing a detailed assessment and giving a diagnosis for the family. So if we talk about the process of evaluation, a lot of times in the therapy centers, which are let's say, not attached to a hospital, right? If it's not attached to a hospital, or not having somebody from the medical background, let's say, what I generally have tended to see is that medical history and developmental history and physical examination of the child, a lot of the neurodevelopmental observations that are very crucial and play a really major role in helping the family and the child kind of gets missed out. So it's not just about taking family history, temperament of the child, doing some questionnaires and assessments of the child, but it's also very important to look at the core developmental problem, physical examination of the child. Are all of the how is the skin? What does the face look like? Are there any signs pointing towards a genetic etiology? What kind of medical history does this child have? A lot of times very subtle things like, my child was talking a couple of things till 18 months of age, and then the child stopped talking those 18 months of age, are missed. And somebody rightly said regression. That's something which is very easily missed, because if it's very subtle, we even never come to know that the child had regression. Sometimes if the child has had febrile seizures, maybe pediatrician has said it's okay, many children have febrile seizures, and with high fever children can get seizures. But if that is in a child who has a developmental disorder, then it's really very significant to share with the treating team, and that requires proper follow up. So some of these things really have to be kept in mind while initial assessment itself at 3 years or 2 years or 1.5 years of age itself. When any of you are seeing a child for the first time, please make sure that the child also gets a detailed medical evaluation. It's very important to assess current behavior and functioning, not just the developmental milestones, but also the kind of behaviors that the child has. So some children are extremely cranky and some children are absolutely not bothered. So what is the level of sensitivity the child has to things around, and what kind of functioning level is the child at? And also, not to rule out assessment of comorbid conditions. Of course, you will not be able to see mood and anxiety disorders in children who are 3 or 5 or 6. It's much common in older childhood and adolescence. But if you're looking at that age group, it's very essential to assess comorbid conditions on a regular basis, not one off, not when there is a peak of a problem, but on a regular basis, check for whether any of these things are emerging, any of these things are contributing to the behavioral problems of the child or to the child's day-to-day activities and functioning. It's also very important to know when to refer. And this is something I think, as a community of professionals, therapists, parents, doctors working in this space, that a lot of people don't do, that you adequately refer. So let's say I am seeing somebody, but I think that this child might have vision issues. I really need to point that to the family and say, please get help, go to an ophthalmologist. If there is something that I am not able to figure out, I probably will say, why don't you get evaluated by a developmental pediatrician or a pediatric neurologist? Go and get this check, because I am not an expert in that domain. Suppose I feel like parents are having interpersonal issues, and that is in some way influencing the overall development of the child, or it's causing the family environment to be not adequately supporting to the child's overall development. I probably will at some point sit down with the parents and say, do you want to see a social worker? Do you want to talk to a psychologist? Do you want to see a doctor who can help you overcome some of these issues that you're having? Because it's obviously very hard for anybody to deal with a child with developmental disorder, and more specifically autism, right? So what is also really important otherwise is to do karyotyping and go for molecular genetics, especially if the child is showing some symptoms of having a genetic etiology. So that is why a detailed physical examination and all of that is really important. In some cases, not in all cases, in some cases, it might be really essential to get a CT scan or an MRI or get an EEG evaluation, audiometry, and all of those things. But above all of these things, I also think it's really important for therapists and parents to get an assessment of community resources. So, what is that they have access to? So, just to give an example, I recently saw a child who is from a well-educated family who are living in the center of Bangalore. I know that the area that they are living in has a lot of good therapy centers, access to a lot of hospitals and doctors and therapists and all of that. But the parents were not adequately able to connect with any of those people because they were not pointed at the right direction. So many times, the first things as therapists we can ask, or as parents we can look for, is also what are the community resources that do you have? Do you have like a parent support group where you can share some of your concerns? Do you have a therapy team whom you can talk to? Is there a family pediatrician who can address your concerns? Or, for the therapy team yourself, is there a particular doctor? Or, it could be anybody for that matter whom you can actually refer to or talk to or ensure that the family actually has adequate resources. One of the really most important things for me is also to get an idea from parents about what do they think of their child's mental age. So yes, your child has autism, this problem, that problem, comorbidity, and all of that. But according to you, what is the level of functioning of your child? So if you ask parents, will say, maybe my child is 3 years old, is functioning like a 1.5-year-old. Maybe they're functioning like a 12-month-old, and so on. So it's very important to see whether there is a lag in milestone or there is no lag in milestone. And coming to the actual core of what I wanted to present, you all know that there are multiple different types of treatment ranging from ABA to PECS to GFCF, speech occupational therapy, and all of the other more well-formed therapy techniques and manuals and modules that a lot of centers use. But sometimes the child can have subtle issues that are treatable or maybe not fully treatable. Like I said, if the child has a comorbid seizure, it is something that is maybe treatable or maybe not fully treatable, but maybe if you're giving medication, it's under control, so it's treatable. There are some things like, let's say, hypothyroidism. Sorry, just a moment, please. So let's say that the child has hypothyroidism, and you supplement the child with thyroid medication, and that probably can help in improving some of these symptoms that the child is having, like probably excessive lethargy, weight gain, cognitive delay. Probably it's a congenital hypothyroidism that was not treated. And you start treating that, and you actually see that a lot of developmental delay starts falling in place. Maybe it is not fully treatable, but definitely things can get better for the child. Something that we also missed talking about, and this was something that I was expecting some of you to put in the chat box when I initially wrote what else should we ask, is whether the child has an eating problem, whether the child has a sleeping problem. And all of these things, how much is it actually contributing to the caregiver's burden? I'll tell you why some of these things are important as we talk about treatment later on, because a lot of these things contribute significantly to distress. Sometimes eating problems, sleeping problems, caregiver burden is far more problematic and far more distressing to some families than the core symptoms of autism themselves. Yeah, the child is not able to communicate, but if the child does not sleep and has disrupted sleep patterns every single day for an entire year, can you imagine the kind of issues the whole family will go through if the child is having this kind of disrupted sleeping patterns? Of course, these are comorbidities that are very, very crucial to deal with and many, many times need medication. So I'll move on to medication, but I'll probably give a minute to see if anybody has specific questions to whatever background I have already given so far. I'll just stop screen sharing and maybe see if you have a couple of questions before. Yes, I see somebody raise their hand. Sir, do you want to unmute and ask
Yeah.
something?
Just one question. You talk about the hyperthyroidism or
Yeah.
hypothyroidism. How many
Yeah.
percent of ASD kids have hypo or hypothyroidism?
I honestly
Not
probably cannot point and say the percentage because I really haven't seen the percentage specifically. Hyperthyroidism is not very common, but hypothyroidism, if you ask me based on my own experience, let us say maybe about 1 to 3% of children or 5% of children I have seen have a comorbid congenital hypothyroidism. And especially if it's a child who has also something like cerebral palsy with autism, or a child who has severe intellectual delay with autism, then I think the percentage of hypothyroidism is even more higher in those kind of children.
At what age? No.
If it's really picked up, sir, I think we can pick it up as early as 1 year or 2 years of age. I have seen a lot of children who were started on supplements as early as 3 months of age or 4 months of age, because I think nowadays it's mandatory for thyroid checkup to be done at birth, right? So if they have done that, and if there is a delay and the pediatrician has picked it up and has started on thyroid supplements, then definitely they would have started taking that from 3 or 6 months of age itself. Sometimes it is missed. There are children who have been diagnosed at 3 years of age, 5 years of age, sometimes even in adolescence, because nobody suspected a thyroid issue, but then they come with depressive symptoms, but it's truly not showing as depression, but it's more, thyroid issues that the child has. And then when we start treating that, all of those depressive like symptoms kind of go away. So it can depend on when the child is actually.
It's better to get the thyroid test done.
About constant eating in the child, and how do we help children and parents? Yeah, that's a very good question. I think constant eating could mean a lot of things. It could mean something as simple as a deficiency in a vitamin or in a metabolite, or it can be an adverse effect of an ongoing medication. It could be related to some of these things that I talked about, like thyroid issues. I also have seen children with autism who have developed, let's say, diabetes in adolescence. Like it's called juvenile onset diabetes, or primary diabetes, where diabetes starts at a very early age. So it could be something like that. It could also be more behavioral. It could be related to depression. It could be related to anxiety. Sometimes it could be related to bullying. It could be related to something that the child is not able to express, but it is happening because the child is having triggers or is going through something specifically. So a lot of things can actually cause excessive eating in children. What about sleeping disorder issues in adults with autism? Yes, I will come to that. And definitely, if there is a sleeping disorder, it must be treated with medication, because if it's a diagnosed sleeping disorder, then there are medications that can actually treat the sleeping disorder and can be really very helpful when we treat it. How to treat infections like fungal or viral infections that cause neuropsychiatric symptoms like aggression in an otherwise calm child. This is a very, very, very interesting and a very specific question. What do you mean by fungus and viral infections? Are you saying this is something that started after an episode of viral fever or something like that? Because just recently, I read a paper that was published in Nature. I don't know if some of you know this really good journal called Nature. In that, what they say is, if a child, even a neurotypical child without a developmental delay, has an episode of fever, the immune axis of the body interacts very, very easily with the brain. And it is very well known that there is a brain immune interaction, and it can cause neuropsychiatric symptoms like aggression. And this can happen very, very commonly in autism. And I can tell you for sure that if I see 20 children who come to me with autism, in that if 5 people tell me that there is a behavioral aggravation, recent onset behavioral aggravation, the first thing I'll ask is, did your child have an episode of fever, cold, cough, viral infection, whatever, in the recent past? And almost 90% of the times they'll say yes. It is something that is temporary. Many times it just needs time, in a month or a couple of months. Most of these aggressive behaviors and irritability and crankiness settle down. In children who are very, very vulnerable, it does not settle down. And sometimes I have rarely also treated these children with very low dose for a very brief period with psychotropic medication, and it has really helped, especially when children start self-harming and it gets to a point where it is absolutely not manageable with any of the behavioral interventions. Then in these children, medication definitely can be helpful. Long periods of medication and its side effects. I will come to medication in more detail because the next few slides are going to be about medication. I haven't put down names of any specific medication because, again, all of these medication have similar requirements, similar kinds of side effects and all of that. Does temporal lobe epilepsy but not seizure? Sorry?
Excuse me, ma'am. I just want to can I just add to the question you were answering? It was my question.
Yeah, please.
Hello.
I can hear you. Please go ahead.
Yeah. So you were saying that you give antipsychotics, antipsychotropics for such children, but doing that does not really target the infection. In my son's case, once the infection passes and we treat it, he's back to normal again. And since he becomes his calm self again.
Exactly.
So how do we treat? Because most of the time my son doesn't even show symptoms. Maybe one cough, one cold, but then if we do not treat it then and there, within 3-4 days he becomes hyper and aggressive.
Correct.
So how do we find that out? There's no test also.
Yeah, no, I agree. I think these are the subgroup of children when we look at autism spectrum disorder as a whole big domain. These are some subgroups of children where their own immune system, their own body's immune system is very, very, very sensitive. So sometimes there are parents who have got some allergy tests and have figured out what kind of things trigger off some of these things. Sometimes parents have some children have, like, vitamin D deficiency or a specific vitamin deficiency which is causing their immune system to be hit over and over again, and treating some of these things or supplementing some vitamins sometimes really is very helpful. Again, you will never know when these infections occur, or and if you're able to identify it quickly, then just treating the infection itself can reduce all of these behavioral triggers and behavioral activity, like you rightly said. And the medication that I mentioned is for the rarest of the cases, even in this subgroup, where despite all of these things, like you've taken care of the allergies, you've taken care of the seasonal stuff, you've taken care of asthma or something else, and viral infections, and treated, and antibiotics and everything. Even after and above all these things, if the symptoms are not coming down, only then I would probably recommend using some of these medications that I specifically talked about. So it's not something that can be done on a day-to-day basis. It's for those very, very rare kind of scenarios, like I pointed out. Thank you very much for that question, because it's a very important group of children who are constantly vulnerable to the immune reactions in their bodies. Does having temporal lobe epilepsy but not seizure warrant medication with anti-epileptics? I think temporal lobe epilepsy is a kind of seizure, and probably a pediatric neurologist should be able to give you more idea of what role of anti-epileptic medication would be in this specific scenario, but it's not something that will directly impact treatment of symptoms of autism. That is what I would probably say. Most ASD kids and adults have behavioral issues, also anxiety, stress, and fear. Do all need medication? Yes, I will come to that very, very shortly, Dr. Ashok. The next question is, if the conditions improve, for example, anger management by taking aripiprazole, is it good to review and stop medication? Absolutely. I will come to this very, very important part very, very shortly. Yes, viral fever, toothache, pandas. If it's pandas, then I think you should go for a detailed evaluation. The treatment for pandas is different. It is something that is triggered by streptococcal infection. It must be treated in a different way. It must really be evaluated properly. So I think if all these things are happening over and over again, this is specifically to Ms. Preetham. I think it's important for you to go for a detailed immune evaluation as well, probably an immunologist who can guide you further about these things. Because if again and again frequent infections or a toothache, even sometimes, adenoid hypertrophy, tonsillitis, and some of these symptoms also can trigger a lot of behavioral problems in children with autism. So it's very important to get evaluated. Apart from comorbidity, what symptoms should we look for? Coming to that, Anjana, very, very shortly. What are the triggers for seizures? Very good question. A lot of times there is no trigger for a seizure. High fever in younger ages definitely is a trigger for seizure. Very, very rarely, there are some rare form of seizures which do have environmental triggers, but seizures can happen without any trigger as well. At least in 30% of children with any kind of developmental disorder, seizures happen because their brains are wired differently. And as they go into adolescence or as their brain growth is happening, seizures can happen because basically seizure is an abnormal electrical activity in the brain. It means that their brain circuits are not interacting correctly with each other, and it can get triggered and cause seizures. So many times we won't even know what is the trigger or what caused the seizure, but children can have seizures. My son with ASD has peculiar issue of remembering things, particularly yellow t-shirt, and if this is not found, it triggers behavior of violent. Yes. So this is something that even in the midnight, and it is definitely challenging. And this very clearly is telling me relationship directly to the core symptoms of autism, where there is rigidity, there is requirement for things to be in a certain way. There is seeking those stereotypes and that pattern over and over again. And yes, it is necessary to address these things if it is causing distress and sleep issues and all of those things. If grandmother is having seizure, can it be a cause for autism? So like I said, autism is not caused by one cause. So grandmother having seizures is contributing to making the child vulnerable to develop another brain related problem, but it does not directly cause autism specifically, right? There are multiple other things that probably would have contributed to the causation.
Can I ask?
Yes, please go ahead.
Many of the kids and adults on the spectrum have got an issue of behavioral issue with anxiety, stress, fear. This thing. All
Yes.
Does it require a medication, and when?
Yes. I'm just going to be beginning to speak about medication. Probably I will talk about it in further detail as to when it is required and how much of distress probably should be there before we consider medication and all of these things. I'll just come to that in a bit, sir. I will talk about it in detail.
Yeah.
If there are stomach problems in ASD, what assessments can be done? Sri Leela, what specific stomach problems? So some children have constipation, some children have diarrhea, some children have gastritis because of different things. So one of the most important things is to evaluate the cause of these stomach issues. So what is that is triggering the stomach issue? And based on that, we can look at what kind of treatment can be offered to offered to this child, and how to relieve those stomach issues for this child.
So
So it
this
could
child
be,
is this child is still independent in indicating toilet needs, but they are
yeah,
not able to identify is it because of the constipation, because there is that mix of these two occurrence of constipation and diarrhea happening,
right.
right? So they are like confused. Should we really, what is that? They are unable to identify the cause of it because the physician, they're not able to identify that, so they're looking for some suggestion. Is there
Yeah.
a dietary issue or something like that?
Yeah. So one of the most important and first steps is to do a detailed dietary evaluation, because if the child is not getting adequate fiber, adequate nutrition, it can cause constipation, diarrhea, or a mixture of both. Sometimes it could be related to gut issues where probiotics can be helpful. Sometimes it can be related to metabolic syndromes, vitamin deficiencies, and just treating that could be beneficial. Many times it could just be behavioral. On some days the child is not feeling not at their best self, and that day it could cause constipation and refusing to go to the toilet and those kind of things. Some days the child is more relaxed and has got a good sleep and is able to just go and use the potty and so on, and on those days it's more easier and easily handleable. So then visual charts and stories and reinforcement and those kind of strategies will be really very beneficial. But if there is like a chronic constipation and lot of distress, then definitely it should be shown to a pediatrician, and adequate intervention, acute intervention should be given. Can one have
Thank
autism
you.
if the child has a family history of schizophrenia? Schizophrenia and autism are very, very closely related. It is one of the major risk factors. So if somebody in the family has schizophrenia, yes, it is possible that there could be other family members who have maybe schizophrenia or a psychiatric disorder, or even autism specifically. Yes, it is possible. It increases the chance, of getting a developmental problem. What are silent seizures and what are symptoms and how to identify it? I think I will not go into different types of seizures. Silent seizures are one type where you really are not recognizing that the child is having a seizure episode. Maybe the child is just staring, or it's happening in the night where you're not even able to understand. There may not really be direct symptoms, but there could be things like, even with adequate therapy, there is absolutely no improvement. You're not seeing any improvement in the child, or the child suddenly had regression and lost some of the skills that the child had developed. Or probably the child is very, very cranky, has lot of behavioral issues, not sleeping well, and you've ruled out everything else. Then probably you can just do an EEG. Just something as simple as an EEG can help to identify it. All right. Who can evaluate stomach issues? No, all gastroenterologists do not understand the connection of autism and gut dysbiosis. It's extremely difficult. I understand from where you're asking this question. From a parent's perspective, it's really very, very hard. I would rather say go to a pediatrician or a developmental pediatrician who's far more aware of autism and gut dysbiosis, and probably they are the ones who can guide you further for evaluating stomach issues in further detail. We spoke about overeating, and there could be multiple triggers that can cause overeating, and that has to be identified. If the child is getting sick almost every month, then definitely look for allergens, look for autoimmune issues, look for hypothyroidism, look for vitamin deficiencies, look for anything that can cause an immune dysregulation. Anjana, that is what you should evaluate. Like, why is the child getting sick almost every other month? It's not okay. There could be something very simple, like the child recently joined school, has more exposure to the common viruses and things that in the environment. Is that why this child is falling sick? Sometimes children may have autoimmune issues, in which case we may have to get more aggressive on the treatment. So what is that is causing all of this is probably what we should really look for.
So
Is
you're
autism a... Yes, Anjana.
So, sorry for interrupting. So you are saying mainly the tests where we can check his immunity and thyroid all those things, right?
Immunity, thyroid, like vitamin D causes immune dysregulation.
Okay.
Vitamin B12 can cause immune dysregulation. Very small things, like simple seasonal asthma, very subtle things can cause a dysregulation. So you have to see what is that is, and sometimes, just getting them to meet a pulmonologist or getting that diagnosis of asthma and the child starts using inhalers regularly or something like that, very subtly, it can put a lot of things in place for the child and can reduce a lot of behavioral issues and triggers, constant triggers.
Mm-hmm. Okay, thank you.
Yeah, yeah. Is autism a childhood schizophrenia or psychosis? Absolutely no. That was what it was thought of maybe 20, 30 years ago. It's no more that. Autism is basically a neurodevelopmental disorder, similar to other things like learning disability, ADHD, cognitive delay, which otherwise we call as intellectual developmental delay. So it's another neurodevelopmental condition, not really psychosis or schizophrenia. So the symptoms are completely different from schizophrenia and psychosis. That is why probably in the early 1990s, autism moved out. It is no more under the diagnosis of schizophrenia. It was removed and completely it's it's under the category of neurodevelopmental conditions. All right. In the interest of time, let me move to the medication part, where I think some of the questions that you've all already asked can get clarified. Okay. So, Sir Michael Rutter is somebody who has researched significantly about autism, Asperger's syndrome, and has written a lot of papers and books about it. And this is a statement from his textbook of autism, where he says, studies have been striking and surprising in their evidence on absolutely no clinically meaningful benefits with respect to core symptoms of autism. So, can we treat speech delay, social communication delay, repetitive behaviors, rigidity, and some of these patterns that come as core symptoms of autism with medication? No. Unfortunately, even to this day, we cannot treat any of the core symptoms of autism. The treatment for core symptoms of autism is only intervention. There is no medication that can help a child develop some of these developmental milestones, because it's not a medical condition, it's a developmental disorder where the brain development, the circuits have not developed according to typically what we see in the world and other children in the same age group or in the same developmental trajectory, right? So unfortunately, to this day, there is no medication that can treat the core symptoms of autism. Like all of you have rightly asked in the chat section of all the different questions, there is immense controversy on the use of medication. Lot of issues, lot of queries, lot of confusion, leading to many times parents thinking, maybe if we take this, symptoms will get improved. Maybe if we take that, something can get better. Or many times parents thinking, if we give medication, then something absolutely wrong will happen to my child. All medication will make my child become dull, or it can cause a lot of adverse effects. So there are so many different kinds of controversies. I mean, it is not necessarily controversy. As a clinician who has been in this field, I completely empathize and understand the parents' perspective. I understand the therapist perspective, because a lot of times parents come and tell me, my therapist has said, stop everything that you're taking. We are only going to do behavioral intervention. But if the child has seizures, then what do we do then? Should we stop the medication? It's only going to do more harm to the family or to the child, right? So instead of saying controversy, I probably should say confusion. Even amongst doctors, there's a lot of confusion the way somebody from a psychiatry background will prescribe medication, somebody from a pediatrics background will prescribe, or a pediatric neurologist will prescribe. But of course, the overall goal is basically to help the child. So let's go with that, right? So the general impression in this area of autism is medication can control specific target symptoms if there is something that is so distressing that is causing significant disruption to the child's daily life, significant disruption to their learning, significant disruption to their progress, to their outcome. If it's causing significant disruption to sleep, to their ability to learn, then we can identify what is that specific target symptom that we want to treat and treat that specific target symptom. So some of the examples I have listed here: aggression, self-injurious behavior, significant hyperactivity, insomnia, that is basically sleep related issues and sleep disorders, significantly severe stereotypic behaviors, very bad seizures and seizures causing regression or developmental issues in the child. So all of these things can for sure, be some of the goals for using medication. And why should we use medication? Because it can help in rehabilitation process. Just to give a simple example, let's say there is a child who has autism with severe hyperactivity, so severe the child is not able to sit in any place, not able to cooperate in therapy sessions, is spitting and biting and kicking and all over the place and running and throwing toys in the therapy sessions, not able to sit down in the house, not able to eat well, is losing weight because of hyperactivity, has sleep disturbances because of hyperactivity, not, even though in a very good intervention setup, is not gaining skills because the child is severely hyperactive. Then what do? If you treat the hyperactivity, then a lot of things will fall in place because the child is able to focus better, the child is calmer, the child is able to participate in intervention. Intervention in turn can help facilitate development of speech, development of cognitive skills, development of joint attention. Occupational therapists can work with this child because the child is able to the child is not kicking or biting or participating well in therapy. So what can really help is this whole process of helping the child come down with some of these specific targets, which can help in the overall rehab process and improving the outcome for this child. So like I said, very common comorbidities, like all of you also listed, are aggression, ADHD, self-injurious behaviors, anxiety, depression, and sleep issues, and so on. Do all of these things have to be treated? No. So somebody asked that question in the chat box. If there is a diagnosis of any of these things, is it necessary for all of these things to be always treated? No. What should we really keep in mind when we are treating? One, there is special care needed while prescribing medication for children. Any child for that matter. Even if it's not a child with autism, let's say we are prescribing just for a child with ADHD or a child with seizure. There is special care that is needed to be kept in mind and given when we are prescribing medication. Second thing is, we have to always weigh the potential benefit of giving medication against the side effect. Am I going to give something that is going to make this child calm? At the same time, is that medication also going to make the child so drowsy that the child is going to miss all of his morning therapy sessions? Then that's the wrong choice, because you're interfering with the circadian rhythm. You're making the child drowsy. That medication is making the child drowsy and interfering in the therapy session. So am I going to pick something else that can be potentially beneficial and not going to disrupt the child's daily life or cause significant side effects? One word of caution that I want to say here, again, I'll come back to this, is in the recent years, use of dietary and alternative treatments have become very popular. But from my background and my perspective, I can only say that this is not backed by sufficient evidence. So we don't really know how effective these kind of things are. Now, let's say I decide that I want to give medication for a particular child. So like I said, we have identified a target symptom. I have identified the need. I know that it's so severe, it is causing disruption everywhere, problems in progress, and problems in the house and increased caregiver burden. School is not able to handle, daycare is not able to handle, and all of that. And I think, yes, this child needs medication for this particular issue, whether it is anxiety, whether it is aggression, whatever it is for that matter. The first thing I'm going to think about is what type of medication does this child need? Probably the child has a seizure, is already on an anti-epileptic drug, which itself can help a lot of behavioral issue. Then, do I want to start another extra medication? Or can I talk to the neurologist and see if we can tweak that dose a little bit, and that itself can help, cover the behavioral issue. So that's the first thing I'm going to think about. What type of medication do I want to give? What is the dose? So one of the things that I honestly practice, and that is something that my mentors have taught me, and that's something I probably will recommend all the doctors that are there in the forum today, is if you're going to start medication, there is one rule that we have to follow. Start low and go slow. Start at the lowest possible dose and hike it very, very slowly, and stop at that point where the child is responding to the medication. You're seeing some positive effect, that's the dose you're going to stop at. It's not necessary for us to always reach the highest level based on the body weight of the child, because it is one of the target symptoms that we are treating. It's not a condition that we are treating. It's not the diagnosis that we are treating. So the higher dose might not at all be required. So those are the first two things that I'm going to think about. Third thing, and of course, this is another question which parents will ask, what is the duration? How long do we have to give treatment? Honestly, some kids who have had acute anxiety attacks or panic attacks, I have treated for 10 days and that's that. There are some kids who have sleep disorders, hypothyroidism, something else, seizure, who probably are on medication for a decade or 2 decades, who really need that. So the duration depends on what is the target of the treatment. So depending on that, we can discuss with the parents of what exactly the duration of treatment would probably look like. The fourth most important thing for me is the target symptoms. So if I am going to start if I'm going to start, let's say, an ADHD medication, am I starting the ADHD medication for increasing attention? Like Anjana is asking in the group, attention in group settings, like in the class, the child is absolutely not able to participate. Then do we treat very, very specifically that attention issue in the classroom setting? Or is this child hyperactive all over the place and really needs that? Or am I prescribing something for sleep? Am I giving something that can specifically help the child sleep better so that the daytime is more relaxed and the child is not cranky? So when we have these target symptoms, informing about those target symptoms to parents becomes very, very important, because you start something and they'll come and say, even after we gave this medication, our child has not developed speech. No, but the target symptom was not speech. The target symptom was sleep. I want the child to sleep well. So the daytime crankiness is lesser. Behavioral issues and temper tantrums are lesser, which in turn probably after a point will also reflect in the way the child is participating in therapy, responding to the therapy sessions. And yes, maybe as a consequence of all of these things, speech might develop. But that medication which I gave was not to improve speech. So that addressing this target symptom, and even for parents in the group, ask the doctor, what exactly is this going to do? And how is this going to help my child? And then talk about what are the possible adverse effects that we are looking at. It could be weight gain, it could be drowsiness, it could be nausea, it could be lack of appetite, it could be increased duration of sleep at night. It could be a lot of things. So probably even before starting it, just talk to your doctors and figure out what are the adverse effects. So for the medication, I'm just going to give you 3 important highlights. This is for everyone, whether you're a parent here or a therapist or a doctor. Highlight 1, always when we try medication, don't fear to do trial discontinuation. So you're treating ADHD, things got better. Parents want to stop the medication and try. We can try. There is nothing wrong in trying. And a lot of times, these children do not need long-term medication, especially if we have one particular target symptom in mind. So it's not necessary that we treat for 2 years, 6 years, or whatever. Sometimes what I have done is we have stopped medication over summer holidays and we have said, okay, you're there to monitor your child. Look, you work with your child and see how it works. I have stopped medication sometimes on weekends and said, okay, school is not there. Maybe the child, even if the child is hyperactive and inattentive, it's okay. There is no school, there's no therapy. Maybe you can manage at home. So can you do that? Yes, we can do it. We can we can try discontinuation on and off and reintroduce if necessary. Medication, always remember, should be used along with other psychosocial methods. It cannot be just a standalone treatment. Okay. Even if it is for self-injurious behavior, even if it is for attention issue, even if it is for anxiety, even if it is for depression, it can never be a standalone treatment. I gave medication and that's it. I'm not going to do anything. No. Pick up the phone, talk to the therapist, pick up the phone, talk to the parent, bring everybody on the same page, talk about maybe the child is anxious. Can we teach the child relaxation techniques? Can we teach the child with using some visual cues? Can we teach the child about calming down in maybe using a sensory space, maybe using a sensory toy, maybe using some food as, to calm down, maybe using other strategies to overcome anxiety. So it can never be like a standalone treatment unless it's something like diabetes or hypothyroidism or seizure, where psychosocial methods can't prevent seizures, isn't it? You need medication. So something grossly medical, something really grossly organic, yes, for sure we can treat it with medication. But if we are looking at behavioral symptoms, comorbid symptoms, then other psychosocial methods must go hand in hand. So again, for me, the highlight here is work as a team, work with all the people put together so we can give the best outcome for the child. Highlight number 2, look at what impact it has on the family. If child is sleeping better, can parents also get good sleep? If parents can get good sleep, maybe their own health will improve. Maybe their own anxiety will come down. Maybe their own interpersonal issues can start getting better. The other way of looking at it is also that you're including family as part of the treatment. You're talking about adverse effects. You're talking about the goals. You're talking about what they have to observe. And a lot of times when parents really come on board and have worked with me, especially when medication is involved, they will actually bring a diary, they'll make a log, they'll tell you on this day, this happened, this triggered, and because of this trigger, he did not sleep well. And after I gave the medication, he was still able to sleep. So I think this behavioral trigger, if it does not exist, sleep can get better. Or they'll come and say, we experimented with one particular kind of food. Maybe the day he ate more fruits, his constipation was better, and that caused lesser behavioral issues. So a lot of times, maintaining a log and having parents one-on-one involved with your treatment plan really is beneficial, because if there is adverse effect, you're picking it up then and there. You're stopping the medication, you're switching it, you're constantly having these kind of discussions with the family. So they also feel like, yes, we are all trying to do the best for the child when we are trying to medicate. Again, it's very important to talk to parents about, and even parents to understand the concept of training, improving functional outcomes, the concept of micro gains. So sometimes it's not necessary that you start treating anxiety and just within 1 week you see improvement. It could take 6 months, it could take 3 months. In some kids, it takes a year before, there is a child who I see who we tried with 3 different ADHD medication, had adverse effects to all of these 3 things. Finally, one of the medication at a very low dose, he kind of settled down, but we have started intervention more aggressively, behavior therapy more aggressively, along with medication. But, still it's like, a little bit of up and down and back and forth with the family. So it's always very important that parents be involved completely and discuss all of these rationales for management and what are the goals that we particularly have to look for. The next most important thing that I wanted to include as part of this presentation is to talk about complementary and alternative medication. So a lot of times parents hear, therapists, all of you have heard of parents using homeopathy, Ayurveda, vitamin supplements, probiotics, GFCF diet, camel milk, something, almond milk, etc., etc., etc. So many other things that are coming in the market very, very regularly. I have some parents who very freely talk to me and tell me all of the kind of things that parents chat, in WhatsApp groups, and tell me that, for some child who was having very specific behavioral issue, I had started the child on risperidone, and the mother just said something in the WhatsApp group, and the whole WhatsApp group started talking about how risperidone can cause a lot of problems. Now, for this particular child, it actually was very beneficial. Child settled down in school, had very less behavioral issues. I did a lot of good for this child, and the child was introduced to mainstream school later on. So, what I want to say and highlight here is, please follow this method called N is equal to 1 method. So I'll just tell you what N is equal to 1 method is. Like all of you know, if you have seen a child with autism, you have only seen one child with autism because the spectrum is so different. Every child will present differently. So parents, if you want to try any of the complementary and alternative medication, think that you're a researcher who's experimenting with your child. Try it for 3 months. Try some, whatever drug you want to give, homeopathy or Ayurvedic supplement or immune booster or whatever. Try it for 3 months. 3 months is a good time for you to see if this particular treatment is beneficial for your child. If it has worked, because there is no evidence, there's no written evidence. I cannot say from my reading in the research literature, for sure this particular thing will help or that particular thing will help. If you think that it has helped your child, like for some children, they really are lactose intolerant, they really are allergic to gluten. For those kids, when you're actually stopping gluten, it can relieve constipation, it can reduce hyperactivity, it can do a lot of good. But if you're doing GFCF in some child who really loves eating paneer and curd and milk, and you're not giving that, and the child is having irritability and those kind of things because the child loves something and you're not giving that, but that child actually is not going to have any improvement just by stopping these kind of dietary things, then there is no point in using that strategy for your child. So this N is equal to 1 method is, if you want to try something that does not have much evidence, try it for 3 months and see if it helps for your child. If it helps, maybe you can continue for another 3 months. If it does not help, stop and move to the next thing, right? So that is probably what I would say about complementary and alternative medication and treatment. Somebody asked in the, I think in the questionnaire, what is the age to start treatment? How young can we start some of these things? Well, if a child has seizure at 6 months of age, 3 months of age at birth, there are anti-epileptics that must be started right from then. But if we are talking about the more comorbid issues, the behavioral symptoms, the attention problems, and other kinds of things that are coming along with autism later on, it depends on what is the age of presentation, the severity of the problem, the triggers, what caused it, and so on and so forth. But probably the earliest I might start medication in a very severely problematic child with a lot of comorbid behavioral issues maybe is only by 4 years of age or 5 years of age, and really not before that unless the problem is very, very severe, right? And some of the medication are not even approved for children less than 6 years of age, right? Some of the ADHD medication and things that we use for self-injurious behaviors and so on, they're not even recommended for children below 6 years. So that's just to give an overview of when can we start. Again, like I said, when we are thinking of adverse effects, it has to basically be balanced between risk and benefit, duration, dose, and what is your goal. Talk clearly to parents about the adverse effects of each of the medication, and then take a call on what exactly you want to start. I have already spoken about this. So it's very important to see that we are addressing every individual, to see that given that child's skill, we are trying to give their best educational, physical, emotional state, and definitely treat something that is very, very challenging, which is interfering in this child's behavior or in learning and long-term outcome. If the child had a sudden onset behavioral change, then it must be evaluated. So somebody is having crankiness for 2 years or 3 years. Okay, we will evaluate. But somebody suddenly developed anxiety in the last 1 week. Emergency must be seen. Somebody suddenly started losing speech skills, language skills, or suddenly stopped cooperating in therapy, must really be evaluated, because a lot of times behavioral issues, GI issues, sleep related issues, sickness behaviors, psychiatric issues, changes in environment, any of these things can really trigger a behavioral problem. And then the treatment for those kind of things are slightly different. The choice of medication are slightly different than what it is otherwise that we give. So already, like I said, take proper history, have good observation, of course, the ABC that we already talked about, record the baseline, frequency of the problem, timing of the problem, duration of the problem, what are the settings in which this problem occurs, who are the people involved when this problem is happening, what is increasing the problem, what is relieving the problem, what are the typical likes and dislikes of the child, what is reward really working or not, and then you develop a hypothesis in your mind and then medicate the child, test your hypothesis, and really record the change in the target problem after you have initiated medication, and sometimes even stop the medication if that goal is achieved very quickly. So medication could be for prevention sometimes, it could be for replacement sometimes, and sometimes it's also for the response of whatever has happened, and we are treating that particular thing. One of the really important aspects that I want to stress and probably conclude my presentation here is on follow-up. If you have started on medication, insist on regular follow-up. I know parents who go off with medication and come back after 6 months and say, nothing happened in 6 months. I'm like, if nothing happened in 6 months, you should have come and told me at 6 weeks or 8 weeks, and we would have hiked the dose, changed the medication, reoriented ourselves towards the goal. You know, blindly just giving for a really long time, or there are parents who also come and tell me, I tried for 1 week, nothing happened, and I stopped it. Again, if we are treating fever, if we are treating with antibiotics, I would expect response in 1 week. But these are medications that are going to act on your brain, are going to try to balance the neurotransmitters. And they don't work so quickly. They probably will need about 3 to 4 weeks of time before we even start identifying improvement. So talking to parents about all of these things, reinforcing the fact that regular follow-up is extremely very important. So again, to conclude, systematically evaluating, focusing on the developmental history, very good history taking and examination, observation in different settings, bringing the whole team together on board, trying to learn about the condition, early intervention, intensive management, having parents, almost as if they are co-therapists, is probably what is the aim of even medication or treatment. And basically, it's to make the youngster as independent as possible, to help him or her reach the best possible potential with the least comorbidities at all points in time, to basically have a better long-term outcome. Just to deviate a little bit, in the beginning, when my introduction was given, Hamshi talked about the club that I run. This is something that me and my husband started a couple of years ago, or maybe 3 or 4 years ago. So we have a trust that is basically related to neuroscience. And as part of this, there is a children's club that I run where everything is related to positive mental health, and we have a range of workshops and products for children and parents, and parent mental health and child mental health, related to basically enhancing positivity in children in the community. So thank you very much for your patience. I'm going to stop screen sharing. And before anybody can probably raise your hand and ask questions, I'm going to take all of the comments that have come in the chat box while I was presenting on medication. So Dr. Gauri, I think we are almost at the end of time.
Sure.
So what I'm
If
going to
you
do,
don't have any issues, we can extend for a little bit. There
okay.
are some questions in the
What I'm going to do
as
is,
well. So
wow,
I will
okay.
let Hamshi read out the questions and maybe one or two, and then we can let the audience also directly ask you questions, if that's okay.
Okay. Okay. So probably we'll extend by 5 minutes. I
Sure.
don't want to keep everyone here because I'm sure it's also your family dinner time and sleep time for a lot of children. So I'm not going to keep you here for long. I had my email and my phone number. If any of you have any specific queries, you can reach out to me. Just leave a WhatsApp message or something like that, and I will definitely get back to you. Hamshi, what I'll do is I'll just go through this chat. Chat. Okay, so, Dr. Gauri has addressed specific visual difficulties. Who is the right specialist to treat ASD in children and adults? I think it's a multidisciplinary approach. So I don't think there's any specific specialist who is more or less capable. But I think somebody who has seen a lot of children and adults with autism, who has a lot of expertise in doing and managing children with adults and children is probably the right specialist. So it could be a pediatric neurologist with an interest in autism, a child psychiatrist, a developmental pediatrician, a general pediatrician. It could be any of those people. But I think it's really important that they have this overall perspective and have a multidisciplinary team who can cater to multiple issues that children come with.
I just asked this question because developmental pediatrician after the age of 18, she refused to treat.
True.
She said you go to psychiatrist. Any specific reason?
No, I think pediatricians also have their own constraints of not being able to treat a lot of adult onset issues and challenges that adults come with, and especially in adults with autism, more than having pediatric like comorbidities, let's say seizure or diabetes or those kind of things. I think adults with autism have other kind of comorbidities like anxiety, depression, OCD, repetitive behaviors, which I think a psychiatrist might be more qualified to treat than a developmental pediatrician. Okay. Hamshi, if you can quickly read out the questions from YouTube.
Ma'am, one more question. Sorry,
yes,
please. I'll be quick. So basically, my son, we diagnosed him at 2 years and 11 months. And this happened because we live in Hong Kong, actually, and we sent him to a Chinese school because I have an older daughter, and then she coped up well. So we didn't think much about it. And then after joining, within a week, he's just completely stopped speaking and started regressing. Okay. So is this one of the environmental factors? Can be considered as environmental?
Again, he will probably definitely need a detailed evaluation. It could be something environmental, but if the regression is very severe, then it's not usually environmental. It could be something more neurological, which definitely needs immediate attention. You must reach out and get him evaluated and look for other causes that can cause regression at that age.
Sure, ma'am. So
regression is definitely a red flag. You must reach out immediately.
So yeah, so after that we just started right away with speech therapy, OT, physical therapy, individual therapy. Everything was on track. We also had ABA therapy included. Everything was going on fine. So February 2023, he just fell sick. As you mentioned earlier, it was adenoids issue. And then he was speaking. He had begun to speak, and it was all meaningful. It was relevant. He was a happy kid. He knew what he was doing. But then again, there was a major regression. And on top of that, I think his dad went for a 3-month business trip. He was not to be seen. So I don't know what happened. Is it fever? Is it adenoids? Is it change in family circumstances because his father was in there? I don't know what happened, ma'am. And then after that, again, he started regressing, potty regression, toilet regression, eating regression, all kinds of regression. And then
Right.
we are on with his schedule and all that. Now he's 5.5, ma'am. I think we lost a lot of time. It was our bad luck. Do you think we still have time?
I think you should meet a neurologist immediately because somebody who
Ma'am,
has
we met Dr. Ravi at Aster
mm,
CMI in Hebar,
mhm,
and
mhm.
we did an MRI scan. We did all the metallic
Okay.
allergy, all kinds of scan. Nothing. There was nothing.
Right, right. So there could have been something that would have happened during the regression, probably has not got picked up now. But as long as he's not continuing to regress, then I think therapy is the way forward, unless there are other comorbidities which need medical attention. Probably therapies are the way forward.
Ma'am, we still have
And
time.
again, I think one more thing is in autism, they're very used to a certain pattern. So if pattern changes, it affects them. So that could be the other reason why
Yeah.
the child is having regression here.
Yes. Thanks.
I think a detailed functional and behavioral evaluation to look at what are the triggers, is there a pattern, is there some baseline anxiety? So sometimes, even if it's something like separation anxiety or a school related anxiety, because they are not able to express, because they are not very verbal or not able to identify emotions, they can have something like a regression, especially if it's like potty and all of that. So I think a detailed evaluation on those lines as well can be really helpful and can be dealt with behavioral interventions.
Sure, ma'am, we'll do that. One more last question. Do we still have time? Or his therapies are all ongoing?
Like I said, neuroplasticity is something that is lifelong. So a lot of times children can pick up skills at ages that we cannot really predict at all. So
Okay.
there are kids who pick up during adolescence. There are kids who pick up after adolescence. So it depends on what his brain is ready to do. And unfortunately, in research or in medical practice, we haven't reached a point where we can say, yes, this child is going to improve 70% or this child is going to improve 30%. We can't pinpoint and say that. But is there hope for improvement? Absolutely. If intervention is going on, there is definitely going to be a slow upper spike, unless there is another episode of regression or a seizure or something else that is really an insult, a gross insult to the brain. If that does not happen, then definitely improvement will continue to happen in one way or the other.
Sure, ma'am. Thank you so much.
Yeah, no problem.
I think one or two from YouTube, I think Hamshi.
Yes, ma'am.
Probably one from there we can address.
Yes, ma'am. We just have two questions, the recorded ones, and then we can open it for discussion. The first question is by Dr. Chitra Shankar. She wants to know if some children who have severe nail biting or picking on the skin, how to manage them.
Mhm. Okay, so skin biting and nail biting and skin picking could be multiple things. So it could just be a sensory issue. It could be something related to anxiety. It could be something related to self-injurious behaviors as part of the ADHD spectrum. Something when the child's demands are not met. Sometimes it's just even that seeking of security. That it's not even to the level of anxiety, but it's just some subtle restlessness that the child has that really needs to be addressed. If probably sometimes it could be just attention seeking, right? They're not able to express what they need, and it could be just that. So I think treatment basically will depend on what is triggering this behavior, because it's a consequence of something that is underlying. So I think the answer to that is to identify what's triggering it. Most of the times it's anxiety. So if it's very subtle, behavioral interventions, but if it's very severe, then medication, it can probably be helpful. Okay.
Thank you, ma'am. Just one more question. A parent wants to know, the question is, my daughter has autism and anxiety. She takes medication for her anxiety. I am seeing weight gain, especially in breasts. This is my concern, the weight gain. Another
Yeah.
concern is about how to reduce her anxiety and help her to self-regulate along with medications.
Okay. Yeah. So I think it's the same parent who's also put the message in the Zoom chat. So I think if there's autism and anxiety and there's medication for 8 years, then you have to look at what is the anxiety like at this point. And if she's older, have you tried adequate psychosocial interventions and behavior strategies to address anxiety? Because um, if you're saying there's weight gain, and especially in the breasts and all of that, hormonal tests, of course, if we start any medication, regular hormonal or blood evaluations for liver function or renal function, all those things is a must. So if we are starting any kind of medication, we should regularly, that is why regular follow-up is essential to address these things. Or there are medications that can cause hormonal changes, it can affect adolescent hormonal changes. So you have to switch to something that's more safer or something that does not cause these kind of adverse effects. Arip, Buspin, risperidone, fluoxetine, anything can cause weight gain. Valproate, ADHD, some of the ADHD medications, some of the anti-epileptics, pretty much anything can cause weight gain. So it's necessary to see whether you have to switch to something that's safer, whether introducing more aggressive behavioral interventions and taking off multiple medication can be helpful. So you really have to get her evaluated, talk to the doctor who's treating her and address some of these issues. And if the child is 20 years old, I don't think a child psychiatrist will see her. You should go to an adult psychiatrist. If possible, then definitely you should connect your child psychiatrist and your adult psychiatrist so that they can talk to each other first and do that formal handover thing so that they are both on board and your adult psychiatrist knows what exactly has been going on with this child for the past many years. So that is probably really helpful.
Thank you.
If there is no problem. If there's OCD, really needs to be addressed. Sometimes it's very difficult to differentiate OCD with sensory issues, OCD with repetitive behaviors, and OCD with rigidity and stereotypies and all of that. So it's very important to split these things, and the treatment for these things are really different. So if it's OCD, it's an anxiety spectrum you're treating with anxiety related medication. If it's sensory issues, then you're doing something else for medication. I have had kids who had to be on both because they have both OCD with sensory issues, and we really cannot tease out and say this caused that, that caused this. In which case, when it's very, very severe, you probably will have to do both of it. So unless and until it's not disrupting their life or causing a lot of distress, and they're just doing it because they need some form of feeling that sense of security or calming themselves down, if it's in that just that case, behavior strategies are what you should really go for and not medication right away. Dr. Ashok, I probably can say that you can ping me on WhatsApp and I can share further details with you.
I think
And
the other thing we can do is if Dr. Soumyashri, if you can give us the details, whoever have registered, we have the email addresses. We will
Sure.
send a short note, whatever you send us, we'll share it with
Sure.
everybody so they can reach out.
Perfect. Perfect. Thank you so much. That will be perfect. All right. So I am based in Bangalore to clear out that last question. And
What email ID for that?
We will share it with you on email, sir. So you must have registered with us. We'll share her details to all of them who have registered.
How will you share? No,
Email, sir. When you registered, you've given us your email ID. So if you've all given us your right email IDs, it will reach you.
okay. So
And she's
I
on
think-
LinkedIn as well. You can find
Yes.
her there.
Yeah, I'm on LinkedIn. I'm on Instagram. You can find me anywhere. Not a problem.
I think you have summed up the whole basis of the medications very well. And we cannot specifically answer specific children's queries in such a short time because like how you mentioned, each individual is different, and the situation has to be analyzed, and then it has to be addressed. So if there's anything further, I'm sure you can all reach out to her and have a consultation and follow up and take it from there. So if we have not specifically addressed anything, that is the reason.
Yeah, thank you so much for all the queries that you all sent in as well. That really helped me in putting together some of the content for this presentation. And I really hope that I was able to clarify some of the queries that a lot of you had. And once again, I really thank the Brainchild Trust, Dr. Gauri, Dr. Hamshi, and all of you for putting this together and having me speak on this very, very relevant topic.
So Hamshi, we can close the session.
Yes. Thank you so much, ma'am. We generally have a lot of parents who think, okay, if this is there, this medication can be given. But you really gave us an insight of how a deeper, comprehensive evaluation is required to even check the need for medication for the child. And it was really nice. And I really appreciate that you told if you have seen one child with autism, then you've seen only one child with autism. I think people need to hear this a lot more. It needs to be spread a lot more. Thank you so much for your talk. And I would like to invite my colleague, who's the physiotherapist, Hansika, to give vote of thanks for today.
Good evening, ma'am. Thank you. Thank you for such an exceptional talk and a presentation regarding this topic. I think your insight about specifically autism has really helped, at least me as a therapist, and I'm sure a lot of other therapists, to look outside of what we are actually doing with the children, like look more in terms of their comorbidities. So thank you so much for that. And I would also like to thank Brainchild Trust for providing and organizing a platform like this so we can all discuss and improve and get better as a community to help children with such impairments and constraints. Thank you so much, ma'am. And thank you to everybody who's been so actively participating in this talk. Really love the questions and the discussions. Thank you so much.
Thank
On
you.
behalf of parents, actually, we are because we have a lot of concern on this medication and all. I thank Dr. Soumya Sri and this brain child for because we got a more clarity and whatever we had oppression, we got a lot of clarity, clear. And thanks once again, Soumya Sri, Dr. Soumya Sri, and Trust and everybody who organized this webinar. Thank you.
Thank you.
Thanks
Thank
to
you so much,
everybody.
sir.
So we will
Thank you.